Hello, everybody. This is Anna Huysse, the founder of Hashimoto Health, the only online evidence-based platform supporting early detection of Hashimoto thyroiditis and preventing those who are diagnosed with Hashimoto thyroiditis to get second or third autoimmune disease. Welcome, everyone. A very interesting and important topic for this evening, early adverse events and autoimmunity. We have a special topic and a special guest. Now, so welcome, Shanta Dube.
Thank you, Anna. Thank you so much. It's such a pleasure to be here today and to talk about a study that I conducted while working on the Adverse Childhood Experiences study, and it focused on the relationship between early life stress and autoimmunity in adulthood. So I want to start with changing patterns of disease that we've seen over the past 100 years in the US as a developed nation. Take a look at the leading causes of death in the US 2016 and 1900. These data are from the Centers for Disease Control and Prevention. And you'll see that currently in the United States, heart disease is a leading cause of death, while in 1900, it was number 4.
Yeah.
Currently, cancer or malignancies is number 2 in the United States, whereas in 1900, it was number 8. Whereas in 1900s, the leading causes of death were due to infectious agents, we now see currently that those fall below number 5, number 8. So what is the point, and what is this all about? This is simply documenting the changes we have seen over the last 100 years, where in the 1900s, leading causes of death were due to infectious disease. And now in 2016, the leading causes of death are primarily related to injuries and chronic diseases. So how did all of these changing patterns occur? Well, we've had major achievements in public health and medicine, improvements in hygiene, sanitation, nutrition, standards of living in the US, better housing, identification, treatment and prevention strategies in 1900 and 20th centuries, with the advent of vaccinations and antibiotics, have really helped push forward these changing patterns. And so that is why in the current time we see this shift where chronic diseases and unintentional injuries are the leading causes of death in the US. And these long-term shifts have really been displaced by what we call man-made diseases. So what do we mean by man-made diseases? Well, when we think about the leading causes of death, we actually want to draw our attention to what are the actual causes. And the actual causes relate to behavioral risks. So tobacco, excessive alcohol use, illicit drug use, poor nutrition, lack of physical activity. These are the actual causes of disease and death in the US. So with that knowledge that we gained in the US with respect to what are the risk factors for chronic diseases, more research was unfolding regarding, well, what are the underlying factors for the actual or the lifestyle or behavioral risk factors? And that leads to what we're going to talk about today with regards to the Adverse Childhood Experiences study. The early research on childhood adversity and health documented that single forms of abuse, such as childhood sexual abuse, physical abuse, contributed to some of those actual and leading causes of death we just saw on the slides before. David Finkelhor actually documented the long-term impact specifically of childhood sexual abuse. But it wasn't until the 1990s that Dr. Vincent Folletti, a physician at Kaiser Permanente in San Diego, California, noted some interesting observations of patients who were in a weight management clinic. These were patients who needed to lose 30 or 40 pounds because they were at high risk of metabolic disease, metabolic disorder. And so they went through the weight management program, and about 1 to 2 weeks into the program, as they were successfully losing weight, they were dropping out of his program, and he couldn't understand why that was the case. So he brought him in for in-depth clinical interviews and learned that a significant proportion of these patients who were dropping out had experienced childhood sexual abuse and other related traumatic stress during childhood. And so what this drew his attention to was that actually the weight was a protective factor. So while in conventional medicine, excess weight, obesity are risk factors for chronic diseases, in this specific case study of patients, it was really protective against emotional triggers and traumatic experiences. So Dr. Folletti's initial findings led to a study that the CDC, the Centers for Disease Control and Prevention in the US, decided was very important to investigate. And so the underlying, or I should say the overarching research question is, what are the underlying factors that contribute to the actual leading causes of disease and death in the US? And so the Adverse Childhood Experiences A study was launched. It was a collaboration between the US Centers for Disease Control and Prevention and Kaiser Permanente Health Organization, Maintenance Organization, a healthcare provider in San Diego, California. It was a large-scale epidemiologic investigation. It was one of the largest with over 17,000 adult health maintenance organization members, where data were gathered between 1995 to 1997. The research studies published from the ACE study spanned from 1998, when Dr. Folletti published the first study, to current day. So today's talk is specifically about cumulative childhood stress and autoimmune diseases in adults. This study was published in 2009 in Psychosomatic Medicine. And so today I'm going to talk a little bit about our findings and how and why this study was developed. First, let's try to understand what are autoimmune diseases. So autoimmune diseases are a heterogeneous group of 80 or more different inflammatory disorders. They affect approximately 3 to 8% of the population in the US. The prevalence of autoimmune diseases, however, is steadily increasing. And the important thing to note about autoimmune diseases is they occur where there's an immune response that damages tissues in the body. So it could be autoimmune diseases are classified by the organ that they target, the tissue, or the system. And the target is based on an immune response. We'll talk about that in a few minutes. Disease may present as early as the 2nd decade of life, but typically peaks in the 3rd to 6th decade of life. And a lot of studies on autoimmunity and autoimmune diseases, both in animal models and human research, has identified some infectious agents, environmental factors, and they're commonly cited as etiologic factors for autoimmunity. To understand exactly what autoimmunity is, we have to, and also how this study was conducted, we have to understand what is the exact immune response. So autoimmune disease immune responses has been classified as T helper 1, or what we call Th1, or T helper 2, or what we call Th2, depending on the release of certain chemicals through these immune responses. There's also a mixed group called Th1, Th2 mixed. Both Th1 or Th2 autoimmune diseases involve cell-mediated and antibody-mediated responses. And these are the responses, and I'll show you in the next slide exactly how they're categorized based on the organ or the tissue that's targeted. by the immune response. So for the purposes of our study, to look at the contribution of early life stress and autoimmunity, we studied the autoimmune diseases by the following mechanisms. Th1, so we grouped certain autoimmune diseases that we know have a Th1 response, mixed Th1, Th2, and then a Th2 response only. Those autoimmune diseases that have been classically thought of as rheumatoid are actually classified for the purposes of this study as a subgroup of Th2 immune response diseases. We also want to note that the risk of autoimmune diseases may increase with age due to increasing Th2 response and increasing number of autoantibodies. So autoantibodies are essentially those that are produced as a target towards specific, one's own specific tissue or organs. So how did we conduct the ACE study? It's important to also have a background of how we carried out the ACE study. So participants were Kaiser members seeking overall health assessment. This was between 95 and 97, and there were 2 waves across these years. Each wave had approximately 8 to 9,000 participants. The participants made a doctor visit to the Department of Preventive Medicine at Kaiser Permanente, and then 2 weeks after their visit, they were mailed the Family Health History Questionnaire, or the FHH, to their home. And in the FHH were questions about their current health status, as well as retrospective reports about their childhood experiences. In all, there were about 17,300 participants combined from wave 1 and wave 2. And the information from the clinical visit was combined with the family health history information. So what did we assess in the Adverse Childhood Experiences study? We assessed 10 separate exposures to adversities. We looked at physical, emotional, and sexual abuse during childhood, and this was assessed amongst adults reporting these experiences before age 18. We also looked at physical and emotional neglect in wave 2 only. And then 5 forms of related household stressors: parental separation or divorce, witnessing domestic violence in the home, in particular towards the maternal figure, living in a home with persons who abused alcohol or other drugs, living in a home where persons had untreated mental illness, and then criminal activity in the home, or incarceration, or the absence of a family member due to incarceration. So I want to point out one of the things that became really apparent during my tenure on the ACE study and at CDC is a clear result of the study and an understanding of patients' experiences is that these experiences often go unrecognized and unsubstantiated. And what we mean by unsubstantiated in US terms is most of the time, child and family services are called when there is a problem with abuse or neglect in a home, or other types of issues that are that can affect a child's well-being. But what we learned from the ACE study is that actually many individuals live and survive the exposure to these early experiences without ever having documentation that it occurred. And so a lot of that can lead to stigma and secrecy of the experiences, which in and of itself in the literature has shown that it can be a stressor as well. Keeping things in, keeping things bottled, that can be an added stress when you can't share those or be validated. And then the other thing we learned at the same time that the ACE study was taking place is the neuroscientists and the neurobiologists were documenting how early life stress in the form of, for example, childhood sexual abuse, neglect, can actually impact the developing child in ways that cannot be readily seen immediately. And that is through an endogenous stress response. So what do we mean? When we get stressed, we have an endogenous stress response that releases certain hormones and chemicals such as cortisol. And what the neurobiologists have been able to show is that this early life stress actually can set up individuals to have chronic stress throughout life, just by nature of the endogenous stress response. But it's not all doom and gloom, and we're going to talk about that throughout the course of this presentation. So going back to the ACE study procedure, in addition to the retrospective reports of early life adversity, the ACE study had a prospective arm. And what we mean by that is we had the opportunity to utilize Kaiser administrative data on hospital discharge, pharmaceutical prescriptions by physicians, and emergency room visits, as well as outpatient visits. And so for the purposes of this current study, we're actually looking longitudinally at hospital discharge data to examine between 95 and 2005 the occurrence of 21 specific autoimmune diseases. We had a total sample of 15,000 that were in the study between 95 and 2005 who did not disenroll from Kaiser Permanente. So that's why 15,000 is a little smaller than the 17,000, because these are Kaiser patients who stayed enrolled during this particular study period when we looked at autoimmunity. So what are the autoimmune diseases that we examined? So as I mentioned earlier, with the help of Dr. Delisa Fairweather, who's done a fair amount of research in animal models, we utilized those animal models and applied them to the ACE study data. And so we grouped autoimmunity based on T helper cell type. And in this case, we're looking at a group of Th1 type autoimmune diseases. And so here we list the autoimmune disease that we examined, the ICD-9 code we utilized, and then which target or organ tissue or receptor that particular disease is related to. So for example, the first one, idiopathic myocarditis, the heart is the target organ, and it is defined as a Th1 type autoimmunity. This is actually presented in the journal peer-reviewed article citation. So then we looked at Th1 at Th2 mixed. And again, this is the list of the autoimmune diseases by ICD-9 code that we identified for this grouping of Th1, Th2 mixed. And then, slides are moving. And then the Th2 type, again, are those that are seen with increased incidence in females. So I should have mentioned, with the Th1, there's increased incidence in males, and in Th2 type, there's an increased incidence in females. And so these Th2 include rheumatic diseases as listed below. And then we looked at Graves' disease, autoimmune thrombocytopenia purpura, myasthenia gravis, and Hashimoto's thyroiditis as a group of Th2 types. So I just want to clarify, this study doesn't look at any individual type of autoimmune disease, and part of the reason for that is studying autoimmune diseases is very difficult because the prevalence is quite low in the population. And so finding enough cases to examine is oftentimes difficult for research studies. So we really wanted to use this model around the T helper cell type. And so we grouped them into Th2. And then we have specifically Th2 type rheumatic diseases subgroup, which comprises of scleroderma, cystic lupus, and Sjögren's disease. I'm not going to go through all of them, but they are listed here. They're also listed in the publication. So now that we have a background of what types of adversities we examined and what types of autoimmunity we looked at, I want to draw our attention to the characteristics of the ACE study cohort. Keeping in mind, this study occurred between 95 and 97 in the state of California in the county of San Diego. So the data are not representative of the US population, but they are representative of the Kaiser cohort and the Kaiser membership there during 95 to 97. So if you take a look at the characteristics, the mean age 56 years, predominantly slightly more women than men in the study population. And in terms of the racial ethnic makeup, 75% reported their race ethnicity as white. Hispanic was the most common group reported next. And that is because in San Diego County, there is a high population of Latinas in that area due to the location and the proximity to Mexico and South America. And then we have 7.2 reported being Asian. So again, these are not representative of the US national demographics, but are more reflective of the Kaiser Permanente patient population. But what I really want to draw your attention to is the educational level. So much of the research that's been conducted in the US around the long-term health effects of abuse and neglect have tended to target or focus on clinical populations or populations in low socioeconomic strata. And so this is an important finding because it shows that what we're going to show is how widespread trauma is in a highly educated population with very good health care in the US. So what did we, I'm so sorry. So what did we find in terms of the prevalence of individual childhood adversities? Well, we found that physical abuse during that period, 95 to 97, physical abuse was most commonly reported. 1 in 5 reported childhood sexual abuse. In terms of substance abuse, that was the most commonly reported form of household stressor, followed by parental separation or divorce and mental illness. You'll note that domestic violence as defined as battered mother is 12.7 or close to 13%. I want to just point out that our measure of domestic violence in the ACE study specifically looked at unidirectional domestic violence, so violence that was occurring to the maternal figure in the home. It wasn't any parent experiencing or any member in the household witnessing any members in the household, which would change that prevalence. It would be much higher if we defined it as such. And then criminal behavior, the absence of a family member due to incarceration, about 5% reported criminal behavior in the home. Because we had the opportunity to look at 8 separate categories of adversities, which was actually a switch from most of the early research on childhood maltreatment and health, which tended to focus on single forms of abuse or maybe 2 forms of abuse, we had the unique opportunity to look at 3 forms of childhood abuse and 5 forms of related household stressors. So we decided to create something called the Adverse Childhood Experiences ACE score, or the ACE score. Keeping in mind, it's a very blunt instrument. It's the total count of ACEs. It does not take into account frequency or intensity of the exposures. But I want to draw your attention to just how common ACEs were in this cohort of adults with good health care and with high levels of education. So close to 2/3 reported experiencing at least 1 adversity during childhood, and almost 40% reported 2 or more. We use this ACE score when we look at ACEs and relationship with health outcomes. We've always looked at individual categories and the increased likelihood of the health outcome. But we also look at the ACE score as a means to document if there are any dose-response relationships. So that is, if as the ACE score increase, is there an increased likelihood or an increased risk for the outcomes of interest that we're examining? So let's get to ACEs and autoimmune disease. Keeping in mind, we looked at 21 separate types of autoimmune diseases, and knowing that Th1 and Th2 occur, the Th1, Th2 immune responses actually have gender differences. We did look at these analyses by gender. So I want to draw your attention to the first slide that shows women and men separately, and then we looked at the ACE score of 0, 1, 2, 3 or more. We collapsed 3 or more because of the number of cases of autoimmune diseases and what we call sample size. The power would have been impacted for us. So we looked at 0, 1, 2, 3 or more ACEs, and it could be any of the childhood adversities that we assessed. And you will see for women, the likelihood of reporting any of the 21 autoimmune diseases increases in a stepwise graded manner. We saw statistically significant differences between women who had 0 adversities and those with 3 or more in terms of autoimmune diseases. With regards to men, we did see increases. However, from a statistical standpoint, overall, they were not statistically significant when we looked at all 21. Then when we broke it down by the immune type, if you recall the groupings we talked about, we found that the ACE score, again, was related to an increased risk of Th1, Th2, and then Th2 rheumatic subgroup. Keeping in mind that the Th1 is more likely to occur in men, and in fact, we did look at each of these groupings by gender and found that women were less likely to have a hospital discharge with Th1 type subgroup, whereas women were more likely to have a hospital discharge with Th2. With regards to the mixed grouping, we didn't see any associations, and Dr. Fairweather and I discussed that at length, and really that group is a mix. It's a mix of the 2 different types of immune responses, so there may be something else occurring that triggers those particular autoimmune diseases. More research is definitely needed to understand Th2, Th1. And then we looked at the relationship between the ACE score and age at when the autoimmune occurred through the hospital discharge data. And what we want to really draw your attention to, with the hazard ratio of 1 being our referent group, if you look at age, it's stratified by age, 19 to 64, and then 65 and greater. We see a strong graded relationship between the risk of autoimmune diseases for persons aged 19 to 64, although there are stepwise graded increases for both age groups. But just wanted to draw attention that ACEs do increase the likelihood that the 19 to 64-year-olds will experience an autoimmune disorder. So this is a slide showing the relationship between childhood adversities and how they contribute to a high level of perceived stress amongst adults. And while it wasn't part of the autoimmune study, I wanted to draw attention to this because it's important to understand how early life adversity can impact adults' perceived stress. So as you can see, as the ACE score increases, so does the percent reporting high level of perceived stress. So here's basically what we learned overall from the ACE study. I've specifically presented the outcome of autoimmunity and stress, but we did multiple studies and multiple publications. to document that ACEs are common and interrelated, and they're associated with some of those actual causes of disease that we talked about that begin in adolescence. So early initiation of alcohol use, of tobacco use, illicit drug use, teen pregnancies. And then into adulthood, we've also documented through multiple studies from the ACE research that adversities are associated with cardiovascular disease, cancer, lung disease, and then some of the actual causes of disease, lack of exercise, smoking, alcohol use, and suicidality and mental health problems such as depression and anxiety. So we saw in our studies direct relationships, but we also learned from the ACE study how important it is to understand the intergenerational cycle of adversity. So what does that mean? What we're basically saying is those ACEs that led to outcomes of, for example, alcohol abuse in the adults that were in the study, for the next generation, those kids may also experience ACEs. Not saying they definitively will, but there's a high likelihood. And talking with social workers and clinical psychologists, there is enough evidence to show that actually there is an intergenerational cycle of childhood adversities. So how does this all come about? As I mentioned earlier, neurobiologists were documenting these unseen impact of childhood adversity, specifically on the endogenous stress response. And what we now know about the stress response is, while cortisol is very important, it's an important response, too much can actually damage our tissues and our cells. And what we're also learning is the immune response can get set off via cortisol release. In children, what we see in terms of this endogenous stress response is that learning can be impacted. The attachment, secure attachment with caregiver is impacted. We also see behavioral, physical, and some forms of mental illness in children. And then there are documented neurodevelopmental changes. Dr. Doug Bremner at Emory University has done a significant number of studies to show differences in the anatomy of the brain between those who were abused during childhood and those who were not. And there have been plenty of studies around orphans in Romania who are severely neglected, where they've done PET scans of the brain and shown deficits in terms of activity in certain parts of the brain, such as the hippocampus and the amygdala. The amygdala is responsible for emotional regulation. In adults, we see the impact persist many times through the autonomic nervous system, and we're going to talk about that in a bit. Sometimes it leads to hypervigilance, which is this ramp up rapidly in the face of stress or perceived stress, and the activation of what we call the sympathetic nervous system, which is part of the autonomic nervous system, responsible for helping individuals when they encounter stress. So what does this all mean? It means that we really need to think about preventing these childhood adversities, because they're all preventable, using a two-generational approach. So what this is saying is, because there is that intergenerational, what we call an intergenerational transmission, and we want to prevent these amongst children, we really have to also focus our efforts on the adults. We have to focus on promoting their health and also recovery and healing of adults. There's a lot of literature right now regarding trauma healing and models of healing related to stress and trauma. So this is a two-generational approach that I talk about a lot in my studies, because even when we talk about autoimmunity in adulthood, we have to think about the ways we can promote our health and promote recovery and healing to improve our well-being. And in some cases, altogether, we are able to rid of the autoimmunity. I too had an autoimmunity about 20 years ago. I know for a fact it was due to stress and some traumatic experiences I had during childhood. But unfortunately, the doctors wouldn't agree with me, which was difficult, but it was okay because I decided to take things into my own hands. I followed their medical regimen, which was high doses of steroids, not fun. But then I gravitated towards the practice of Ayurveda, which is an ancient healing system of India, to focus on meditation, exercise, diet, sleep, and yoga as part of a regular lifestyle routine I integrated. So let's talk about what we can do and what some of the research that I've been so passionate about looking at the salutogenic model. What is the salutogenic model, you say? Well, as opposed to looking at pathogenesis, which is what we did in the ACE study, we looked at risk factors related to disease outcomes. So with the autoimmunity, we looked at the risk factors of adversity and the disease outcome. Salutogenesis, this model really suggests that we have this innate capacity to learn and adapt towards health and well-being. And I can speak to that in my own personal experiences with autoimmunity, because I did not want it to, it was very scary. It was a very scary experience, but I did not want to be, I wanted to have some autonomy and responsibility over my well-being. So that's how I learned and I adapted. I changed my diet, I changed my lifestyle, and I integrated a lot of stress management. So the salutogenic model posits that it's a stress-oriented concept, and we focus on health resources, not just the material resources, but our own psychological resilience as a resource. And it's a way to maintain and improve health. And when we talk about health in a salutogenic model, we're not just talking about our physical health. So that's another way it diverges from the pathogenic model. We're really talking about multiple dimensions of health. So our physical, our emotional, our mental, social, intellectual, all of that is, it comprises of the salutogenic model. So we really want to focus on positive health as an outcome and look at what are the factors, what are the protective or promoting factors that lead to positive health outcomes. So under this larger paradigm of salutogenesis, we can think of healing and recovery, having purpose and meaning, these personal resources, modifiable behaviors, as I mentioned with my own experiences, resiliency and post-traumatic growth. So one of the key things we need to understand is that while the ACE study and the neurobiological sciences document that the early stress can negatively impact neurodevelopment and development overall, because we have the salutogenic model, we have post-traumatic growth, that theory, as well as resiliency, we as humans have the capability to adapt and promote our well-being in the face of adversity. And that's what this model really speaks to. So I just want to briefly present 3 studies I conducted amongst how I defined adult trauma survivors as those adults, for example, in the Kaiser study who reported 1 or more childhood adversities. And I repeated this study in a completely different data set called the Behavioral Risk Factor Surveillance System. And again, looked at adults who reported 1 or more childhood adversities. And then I also took part or was involved in a study in Oregon, in the state of Oregon, called the Trauma Healing Project. It was a community-based participatory research that involved adult trauma survivors in their, and to understand their healing and how they overcame their adversity. So I do want to present this because this is very relevant to when we think of promoting our health and promoting our healing and recovery. So in the Kaiser cohort, and I just want to say, I've presented the Kaiser study for almost close to 18 years. And I can't tell you how many times when I've presented, I've gotten the question, well, you had 17,000 participants. Did you not look at what helped them survive? Like what helped them overcome? What were their resiliency, factors of resiliency? And actually, truth be told, the ACE study wasn't designed to look at resiliency. It was really based on that pathogenic model to document in a large sample of individuals, what is the contribution of early life adversity to adverse health outcomes. So I decided it was time to kind of shift that paradigm and look at the trauma survivors, those adults in the ACE study cohort who had one or more ACEs. And there were about 5,000 in wave 2. I think I mentioned there were a total of 8,000 in wave 2. So there were about 5,000. Remember, 2/3 had one or more ACEs. So to understand what were the factors related to their mental well-being and their physical well-being, we looked at the standard form 36 to calculate their mean physical health component score and their mental health component score. And in particular, I looked at 4 health promoting factors that are evidence-based: physical activity, smoking abstinence, having some emotional support, and educational attainment. And educational attainment was defined as having anything greater than high school or greater. So anything high school or greater was considered educational attainment. Because in the US, we have public education that is afforded to all individuals. So just to orient you to this, graph, on the y-axis is the actual score, and PCS represents the physical health component score, and MCS represents the mental health component score. And I looked at the relationship with the health promoting factor score of 0, 1, that's represented by the blue bar, and 4, total of all. And you can see for those adults with one or more ACEs, there was a statistically significant difference if they didn't engage in any of those health promoting factors versus if they engaged in all 4. These were the only factors we had in the ACE study. Remember, I said folks had asked me, did you look at resiliency? And the study wasn't set up that way. But given education was so high in this population, we did have one measure of emotional support. I thought it would be interesting and important to document, just exactly the salutogenic model amongst adult survivors. I then wanted to repeat this study as close as possible using a completely separate data set, one that utilized actually population level data. So this is not representative of the whole US population, but it's representative of 5 states that assessed adverse childhood experiences. And so I looked again at those adults with one or more ACEs, and that was about 12,000 in this study population. And instead of a mental health component score, the behavioral risk factor surveillance system has something called physically unhealthy days and mentally unhealthy days. And it's basically asking respondents to say, how many days in the past month were you mentally unhealthy due to stress, emotion, and physically unhealthy? So on the y-axis, we have the number of days, and these are the mean number of days. And again, we did look at the same health promoting factors, physical activity, smoking abstinence. In the BRFSS, they had social and emotional support, and then educational attainment. And looking across the health promoting factor score, you can see actually that the unhealthy days, both physically and mentally, decrease in a statistically significant manner as the health promoting score increases. So again, these are amongst adults who reported one or more ACEs. And finally, drawing your attention to healing and recovery from a mixed methods design of community-based participatory research, that the participants were asked what helped or would have helped. with overcoming the adversities. And so in the qualitative portion, we found that participants talked about safe relationships, human connection, shared experiences, validation, and being able to make some of their own choices and actions in their own healing. Being engaged in school. I remember when I talked to the panel in Oregon, and I got to learn their personal stories and triumph of some of the most incredible, and some of the most unbelievable stories I had ever heard. And one of the things that definitely came through was their wanting to pursue education, and many of them were actually pursuing masters in the helping profession, so social work, psychology. Not that they still weren't having to work through the adversities. Many of them had therapy dogs and were still undergoing their own recovery and healing. But the fact that when we think about salutogenesis, they brought purpose and meaning to their lives, to move on and to take care of themselves and to ultimately want to help others. So being engaged in school is a huge, huge, huge piece in my mind for another reason. And that is because we know the brain is there's plasticity to brain. In other words, as adults, we can continue to learn and develop synaptic connections through our continued learning. The trauma survivors also mentioned movement. So being engaged in exercise, but other type of body work, maybe that it doesn't seem so mainstream, such as yoga, massage, and dance therapy. They also mentioned alcohol and drugs to cope. I think that's important to point out because they were forthright and honest that they did use substances to sometimes manage emotions. And I think that's an important aspect of healing and recovery we have to pay attention to. Yeah. So we're a modern healthcare system in the US, and we're dealing with a lot of different issues here, and one of which is high healthcare costs and an increased dependency on pharmaceuticals. So what does that really mean for us, for humanity in general? I think this is where we really need to think about promoting resiliency, healing, and recovery. So for those of you, because we started out talking about autoimmunity, I can tell you from my own experience that changes in lifestyle, stress reduction are all areas that can really promote well-being, promote resiliency and healing. Our body is equipped to heal and recover. That's why we have positive neurochemicals. So we have the cortisol that's responsible for the stress response, but we have endorphins and other neurochemicals that are actually positive for our well-being. So going back to this 2-generational model, just want to recap that we're really talking about the adults. Not that we're not talking about children and adolescents, definitely adolescents. If we identify the trauma and the stress early and get them interventions, there's definitely a lot of hope. But we have to be able to recognize that realize that trauma is widespread and recognize the symptoms. So for that, the Substance Abuse Mental Health Services Administration, which is a federal agency in the US, has this trauma-informed framework, which is actually swooping our country right now. I mean, you see everyone talking about trauma-informed care. It's been introduced into certain states in their legislation that it is required by schools and child welfare individuals. And I do want to say it was informed partially by the ACE study. And one of the things that we need to keep in mind is trauma can occur in different types of forms. So in the ACE study, we specifically looked at childhood adversity in the form of abuse, neglect, and household stressors. But what the trauma-informed framework draws our attention to is that we can't ignore other types of traumas caused naturally through accidents, through technology, as well as intentional acts. And the other thing I want to say about trauma and stress, it's really critical, is there is a subjective component to it. So for example, something that I perceive as stressful may not be perceived as stressful by my spouse. And what is perceived as stressful to him may not be perceived as stressful to me. The important thing within a trauma-informed care framework is that we recognize the stressors so that we have an understanding of each other. And understanding that if stress A causes a response in me, then my stress response is occurring. There's a physiological response occurring. If stress B is occurring in, say, my spouse or my boss or my colleague, that is their experience, but they have a physiology that's responding as well. So what is that physiology? What exactly is happening? So everyone's familiar with fight or flight. This goes back to Hans Selye's work, Lazarus as well. When they're basically 4 stages. And what most people may not realize is stage 1 is the very first stage starts with our 5 senses, because it's through our senses that we take in information. We don't get information any other way except through hearing, seeing, maybe touching, tasting, and smelling. So if we're seeing something stressful that we perceive or is actually stressful, that is coming through our sensory input. And then the brain has to decipher, is that really a threat or is it okay? And that's a quick process, but as soon as the brain deciphers that there's a stress going on, the body is activated. One of the ways the body gets activated is through the autonomic nervous system. And the sympathetic nervous system is part of the autonomic nervous system that kicks in when we have a stress response. In stage 3, that stress response stays activated so we can act, so we can figure out what we need to do to either fend off the threat or run from it. So that's why we have a fight or flight. We also have something called a freeze response. We all have it. And this has become more and more recognized in the traumatology area, as well as just in general with the stress response. And here I have what we call a deer eye and headlight. And essentially this deer is freezing because it's seeing an oncoming car. So it's not fleeing and it's not trying to fight the car, it's freezing. The interesting thing about this deer is after it experiences this freeze response, it will run and dart to rid itself of the impact that freeze response has had on its physiology. In humans, that doesn't always occur. So when there's a freeze response, we don't go out and go running. Sometimes folks might go exercise. That's a very important way to release that negative energy that might be there. But in general, many times what happens is that freeze response gets stored. It gets stored. So that's stage 3. And then when the body returns to homeostasis through the parasympathetic nervous system, that's when we come back to calmness. I will say from my perspective, I believe society today is relatively more or less in stage 3, constantly in stage 3, activated, aroused. There's a lot of stimulus. There's a lot of, social media, news, everything that bombards our 5 senses constantly. And so our body has a tendency to stay aroused. So going to stage 4 is so key critical, and that's where self-care and self-management must come in. Because honestly, a doctor's not going to be able to get you from stage 3 to stage 4. They might be able to help a little bit with maybe some prescription medicines, but we have actually the capacity to build our parasympathetic nervous system. So if you take a look at this little chart, it's just an example of how stress can manifest and the symptoms that can manifest in our body, mind, behavior, and emotions. By and far, this is not an exhaustive list. This is just some of the symptoms. You may experience other types of symptoms when you're stressed, and it's good that you have an awareness, because those symptoms should be a flag for you anytime you have those symptoms that you need to either slow down or think about how are you going to get from stage 3 to stage 4, get back to calmness. So what happens to us? So this is the autonomic nervous system split into the parasympathetic and sympathetic. So when your 5 senses take in whatever it takes in, and the brain deciphers and decides this is a threat, the sympathetic nervous system goes into action. And this includes, it inhibits the flow of saliva. What does that mean for our digestion? Well, the mouth actually is the first place of digestion through the saliva. The amylase is actually a key enzyme that breaks down carbohydrates. So if stress is there and you don't have enough saliva, your digestion is going to be affected. It accelerates our heartbeat. It dilates our bronchi. It creates, increased breathing for us. I don't know if anyone has ever noticed that their respiration increases. So a lot of things occur physiologically to us immediately through the stress response. And so when that threat goes away is when our parasympathetic nervous system kicks in, and that helps to create an opposite effect. But what folks don't realize is we can actually tone our parasympathetic nervous system through deep breathing. So when someone says you're stressed and someone says just breathe, they're not saying that just for saying it. There's an actual physiological response, and it actually impacts the parasympathetic nervous system so that it can get activated to reduce the activation of the sympathetic, to help with the stress response, so that your body doesn't go into that stage 3 and that there's an easier transition from stage 3 to stage 4. The other important thing you need to be aware of is the vagus nerve, which is the 10th cranial nerve, is the largest cranial nerve in the body. It runs from the back of the neck down, and it innervates all of the organs. And the parasympathetic nervous system is directly connected to the vagus nerve. So when we practice exercise or positive sensory inputs, be it being in nature, going for a walk, laughing, singing, all of those activities actually impact the parasympathetic nervous system in a very positive way, which helps to tone the vagus nerve. So it's ready to be more resilient when you're in the face of stress. So applying trauma-informed principles based on this SAMHSA guideline, realizing trauma is widespread, so it includes all children, including adults. It's intergenerational. There's historical, cultural, and gender-related trauma as well. So we're not just talking about childhood abuse and the factors that we looked at in the ACE study. It's much broader. And then recognizing the symptoms. So I work with teachers right now, and when young kids come into the classroom with a lot of behavioral problems, one of the things we're teaching teachers is to understand that they're not bad kids, that behaviors are actually a nonverbal form of communication. Kids don't necessarily know how to process their stress, so they may have emotional problems or may have outbursts or maybe a little oppositional with the teacher. And yes, while that might seem like a bad behavior, there's always some underlying factor leading to it. So that's an example of recognizing symptoms, and then recognizing symptoms in ourselves. Being responsive is using key strategies such as promoting safe, supportive environments where there's peer support, there's trust built, there's collaboration, empowering one another, having voice and choice, and then resisting re-traumatization. That's where the self-care comes in. The transition from stage 3 in the stress response to stage 4, and utilizing self-care to enhance resilience and manage stress. So here are some trauma responsive strategies that we talk about when I teach teachers. Safety and support, it's about our body language, our facial expression, being non-judgmental, being mindful of our tone and our voice, trustworthy and transparency. This is where trying to find that safe space where you can communicate to somebody about your feelings, being open and honest and not bottling those feelings up. Peer support, learning to understand each other. Again, it goes back to that example I talked about with, one person's stress may seem trivial to you, not to judge or to diagnose. That's their experience and that's their response. Collaboration and mutuality, knowing that when you're in a family unit or in a work situation, that you're all working for the same cause, and to learn from each other, because we are lifelong learners. We have that capability. And then empowerment, voice, and choice. Everyone needs to be heard, so let's listen. And then just recognizing that trauma is much broader than ACEs, the ACEs that I presented in the research, that the trauma-informed framework really embraces trauma as very widespread and as multiple different types of exposures. So in summary, the Adverse Childhood Experiences Study has been in place for close to 2 decades, and we've learned a great deal in terms of how early life stress can impact health across the lifespan. And I hope today you have a better understanding of some of the factors related to autoimmunity and the importance of promoting our well-being through self-care, and understanding that we are lifelong learners, and we can actually heal and recover from early life adversity. Thank you.
So wonderful. Wonderful, Shanta. I would like to thank you a lot for presenting the adverse childhood experiences model, and also showing the relationships with autoimmunity in our health, but also making very clear that trauma is more than adverse childhood experiences, and that we are all in some way the same, but we're also different. And that there are also sometimes small t, as we call it, small traumas that may contribute to our disease. And I'm very happy and thankful to you that you also made some disclosure and showed that you shared your own story with your autoimmune disease, and shortly said how you handle it, and also giving hope, and with presenting the Salutogene model, with the fact that this is not the end. Even if you experienced more than 3 early adverse events, this is not the end, and it is giving opportunity to grow and self-develop, and talking about resilience was very helpful. Thank you so much.
Thank you. When I had my own autoimmunity, I didn't feel sick. I was presenting with symptoms that were odd, but I didn't feel bad. Like, everyone was like, after I was diagnosed with the autoimmunity, like, how are you feeling? I'm like, I'm actually fine. It's just my body is responding in a weird way. It was like out of my control, completely out of my control. Like, why was my body attacking itself? And I will tell you, although the doctors, I had a wonderful physician who was taking care of me, but whenever I brought up stress, never. It was always some kind of either, they told me it was due to childbirth, because I had just had my daughter a year and a half earlier, or they attributed it to being exposed to some kind of hazardous material, which
Yeah.
I don't know what it could have been, or they said it might have been viral. So they were really trying to pinpoint it on something biologic, or that would create a biologic, interaction,
Yeah.
without thinking that stress, even though that's something we perceive, it's still physiologic,
Yeah.
and it still creates a biologic response. It's non-biologic maybe in the beginning as a sensory input,
Yeah.
but that it becomes biologic.
Yeah.
But
Yeah.
I mean, yeah.
And I think this is also, I'm very happy that you opened this point. This is very often with autoimmune diseases, they are slow in development. And it is very important that we
Yes,
can recognize it as soon as possible, even before the disease manifests completely. So you have
absolutely.
stages of the disease and the development, and it's very important that we are also very self-aware and be able to tackle it as soon as possible.
Yeah, so I started on a very strict regimen of meditation every day. It's just a very strict regimen of self-care.
Yeah.
And I journal because there is research to show by Dr. James Pennebaker. I don't know if you're familiar with his work, but emotional disclosure,
Yeah.
where he's actually done randomized controlled trials to show the physiologic impact of emotional disclosure through writing.
Yeah.
And so I journal, and I mean, I had, the doctors could only do so much for me.
Mm-hmm.
And at the time it was those high doses of steroids to, reduce that immune response, right? That's what steroids do. They block antibodies, right?
Yeah.
So, but that just, and high doses of steroids. So we're not talking about, the level that we take when we have, high level of corticosteroids were given to me.
Yeah.
So I didn't have a choice but to really think about, what am I going to do to change my lifestyle? It was really, honestly, the onus was on me. I had to really think and dig deep on how I was going to conquer this.
Yeah, I think probably was also important to say that it's not something what you did for a week and for a month and then you stopped. This became a lifestyle for you, isn't it?
This was 20 years ago this occurred.
Yeah.
Well, let me see. 1999. So next year will be 20 years. It's 19 years.
Yeah.
I rounded up to 20. But yes, absolutely.
Yeah.
I've had to watch myself and continue a particular regimen.
Yeah. So this is the positive side of it, isn't it? It gives you an indication.
Absolutely. And I feel, honestly, I can't go a day without exercising.
Yeah.
I do, because sometimes work gets in the way, but it's difficult. Exercise is like medicine for me.
Yeah.
Because I know it's releasing my endorphins and my positive neurochemicals and neurotransmitters.
Yeah. Great. So we see each other in the next webinar. Shanta, she would talk more about really application, isn't it? This is what you're planning to do.
I want to talk more about some of the self-care practices we can engage in.
Yeah.
That will help us, and then we can have a dialogue about it.
Okay, great. Looking forward to that.
Thank you.